Hello, everyone. Thank you for joining us for the Researcher of the Month video telecast here. My name is Dr. El-Khoueiry, President of the Medical Oncology Association of Southern California. One of our priorities this year is to highlight wonderful research being done by members of our community here in Southern California. For the month of October, we are excited to acknowledge Dr. Anthony El-Khoueiry at USC for his work in clinical and translational research. Dr. El-Khoueiry is an associate professor of clinical medicine in the Division of Medical Oncology at the Keck School of Medicine at the University of Southern California. He is a member of the Gastrointestinal Cancers Program and director of the Phase 1 drug development at USC. He has been at USC since 2007. His primary interests include development of novel drugs for the treatment of solid tumors, particularly gastrointestinal malignancies, as well as being a leader in the field of hepatobiliary cancers. Dr. El-Khoueiry, we're excited to have you, and congratulations on your excellent research, and we're excited to have you here.
Thank you, Dr. El-Khoueiry, for having me. This is a great opportunity for us to get to know each other in the community and what work's being done. I've been at USC since 2004, actually, a long time. As you had alluded to, I kind of have two areas of interest. I'm a GI oncologist and I treat all GI cancers, but my particular focus and research is in hepatobiliary cancers. Particularly hepatocellular carcinoma and cholangiocarcinoma. And then the other area of focus is early drug development. And our portfolio now is quite rich with novel immunotherapeutic agents, some cell therapy, and to a lesser extent, some targeted therapies as well.
Perhaps you can highlight some of the areas of your hepatobiliary research.
Yes. So, for hepatocellular carcinoma, as you all know, the standard of care currently for most patients who are candidates for immunotherapy is to get immunotherapy combination as first line. So it's atezolizumab, bevacizumab, or now, since yesterday, we got the approval of Trami-Durva for HCC. So we have quite a bit of research trying to augment these combinations. So doing triplet research, so looking at a third drug being added to the backbone of atezolizumab, bevacizumab. We have at least two such trials, one looking at a LAG-3 antibody in addition to atezolizumab, bevacizumab. Another one looking at an interleukin-27 antibody, which actually seems to potentiate many of the immune cells in the body beyond just CD8 positive T cells. So both of these are frontline trials. We have actually a series of second-line trials and beyond. One of them includes a second-generation CTLA-4 antibody called botensilimab, where it's given with PD-1. We could use this post-atezo-bev. We also have a novel agent that's an RNA-based agent that targets something that targets a specific protein that actually plays a critical role in myeloid-derived suppressor cells. When you use this compound in preclinical work, you show a significant decrease in myeloid-derived suppressor cells, which are the bad cells that you don't want in the immune microenvironment. And both in preclinical work and in early phase 1, there was a signal of activity in HCC. So now it's actually being given in combination with Pembro as a second or third line type therapy. We also have an OX40 antibody. OX40 is an agonist, right? So this is like stepping on the gas pedal for the immune cells rather than removing the brake. This is a second generation OX40 antibody, and that trial is open for hepatocellular carcinoma as well. Briefly on the cholangiocarcinoma front, we mostly have second, third line trials and beyond. One of them I'll mention because there's been great exciting data shown at ESMO. It's a relay compound that targets FGFR2. This is a common alteration. Well, it's 10 to 15% of cholangiocarcinomas. But for that disease, it's relatively common. So this is a second generation FGFR2 inhibitor. So that's very selective. It has less of the side effects of the FGFR2 inhibitor, especially less hyperphosphatemia, and it seems to be quite potent. So the data that's publicly released shows a response rate of over 65% in previously FGFR naive patients. And it does have activity post-FGFR2 inhibition, meaning patients who had pemigatinib or infigratinib and progressed, it still has activity in those with a response rate of up to 40%. So very exciting compound that's also in trials now. So that's quickly for hepatobiliary.
And you want to highlight some of the areas of your phase 1/2 clinical trial, or I should say drug development for solid tumors?
Yes, thanks for that opportunity. Maybe I'll hit two kind of interesting concepts. One is the compound I just mentioned earlier, botensilimab, a second-generation CTLA-4 antibody that has an Fc-enhanced component that creates a tighter synapse with the antigen-presenting cells. What that does is it just doesn't inhibit CTLA-4, right? Which we know is a checkpoint protein. But what it does, it actually stimulates dendritic cells. It helps with the recruitment of CD8 T cells to the tumor. Seems to actually lower some of the suppressive cells like MDSCs. And we've seen activity with this compound, both as a single agent and in combination with PD-1 in traditionally cold tumor that do not respond to CTLA-4 inhibition like IPI or Nivo-IPI. And we presented data at ESMO GI with a very intriguing signal in microsatellite stable colon cancer with this combination, where patients without liver mets had a response rate of 42%. This compound in combination with PD-1 is being taken forward in multiple tumor types into phase 2, including colon, melanoma, pancreas, and we currently have also a phase 1 expansion in multiple tumor types, including lung cancer, including HCC, and it allows prior PD-1 exposure. Go ahead.
I was going to ask, can you tell us the name of that compound one more time?
Botensilimab, B-O-T, botensilimab. It's also known as agent AGEN 1181. The name is recent.
Very exciting.
Yes. Another just kind of scientifically exciting area is the area of bispecific antibodies. I'll speak about a specific one called AFM24, which binds to EGFR on the surface of tumor cells and to NK cells on the other end. And as a monotherapy, it seems to do some exciting stuff. It recruits NK cells into the tumor. So this is working on the innate immune system. But we also see that it recruits CD8 positive T cells. We've had some prolonged stability of disease with it as a monotherapy and some target tumor reduction. But it's currently being also combined with autologous NK cell infusions. And this is the trial that I wanted to mention. It's super exciting. So NK cells are removed from the patient by leukapheresis. They're expanded and stimulated ex vivo. And then we go ahead and give the bispecific antibody followed by the NK cells. And the idea is we are bringing these stimulated, expanded NK cells to the tumor and hoping to really achieve quite a bit of activity with both a bispecific and an autologous cellular therapy.
I think bringing the bispecific technology to solid tumors is really exciting based on the results we're seeing in hematological malignancies.
Yes, absolutely.
Dr. El-Khoueiry, thank you so much. We've learned quite a bit, and we appreciate your time with us, and we will make sure to have some of these trials that you have discussed regarding these exciting new agents attached to this video. We thank you and talk to you soon.
Thanks very much for having me. Have a good day.